Are you looking to understand multidisciplinary care and endometriosis? Then this webinar is for you. Endometriosis is a disease that affects multiple systems and multiple organs. And in this Endo Summit Live, please join Dr. Mona Orady, Dr. Yaniv Larish, Dr. Joe Raccuia, and Sally Sorrell, your host, to discuss all the ways that endometriosis requires a multidisciplinary team. Stay tuned. Good evening, Facebook Live, and welcome to the second edition of this year's Endo Summit Live. This evening, we're talking all things multidisciplinary care regarding endometriosis, because endometriosis is really not solely a reproductive disorder. And we have three amazing guests this evening. The first is Dr. Mona Orady. She is president of SLS, and I'm going to let you introduce yourself. Welcome, Dr. Orady.
Thank you, Sally, and thank you for making me part of Endo Summit and part of these live events. And I'm looking forward to the Endo Summit and upcoming in February. I am in charge of the president of the Society of Laparoscopic and Robotic Surgeons. It is the first multidisciplinary society, and it's really a wonderful place that we get together, talk about minimally invasive surgery and advancing minimally invasive surgery as a multidisciplinary team. And it's perfect for endometriosis because, as you know, endometriosis affects multiple organs across multiple disciplines. And it's really a place where we network and work together to really improve education, improve minimally invasive surgery and care for our patients. I work in San Francisco at the Dignity Health Medical Group Center for Advanced Gynecology and Minimally Invasive Surgery, and I see endometriosis patients every single day and operate on them every single week. And I'm always trying to continue to learn and advance and share our experience and our knowledge with my colleagues. And Endometriosis Summit is one of the best places to do that.
Oh, we love hearing that. That's so nice. I wonder, when you chose a specialty, what drew you to GYN surgery? Because you're a very advanced surgeon. It's not an easy thing to learn at all.
Yeah. Honestly, what drew me to GYN surgery is the fact that I felt that women were so unheard. And I, being a woman and being unheard myself on multiple occasions, friends, family, I always felt going through medical school, residency, that women were just completely unheard. And it seemed like anytime a woman would complain about whatever it is, pain, bleeding, yada, 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 they were always just given birth control pills or thrown, the pill was thrown at them or a hysterectomy was thrown at them. And I just felt like that's just ridiculous. Like, why aren't we getting to the root cause of the problem and treating the problem at its root rather than just using a Band-Aid with birth control pills or doing something so drastic as a hysterectomy, which is something I would never accept. And that's kind of what led me down this path of becoming a menstrual disorders expert. Over the last 20 years, I've traveled the entire world learning from so many experts from all over the place, and have just continued to grow and advance my practice and advance the field. Learning and working with surgeons from all over the world is really the best way to do that. And obviously learning from my patients. I can't thank my patients enough. I've learned so much from them. And I'm constantly, awed at their experiences and what we can do as a team.
Yeah, I think it's amazing to have a team in the OR. And joining us in the rest of the webinar is a fabulous team that's part of that multidisciplinary care aspect. We have Dr. Yaniv Larish from as a urologist. I know he's waving. Dr. Larish, do you want to go ahead and introduce yourself?
Sure. So Dr. Larish is what my mother calls me, but I that's fine. So I'm a urologist, and I have a special interest in minimally invasive surgery, in reconstructive urology, and in functional urology. And what drew me to endometriosis was that I found, just like Dr. Orady just mentioned, doctors don't really listen all that well sometimes. And I found that a collaborative team that listens to the patient oftentimes uncovers diagnoses and problems that a single specialist with their very sort of narrow lane may not necessarily uncover. And so I sort of put on a detective hat every time I have a consultation with a patient, and I try to think of patients as more than through the lens of a urologist, more sort of, I try to think of it form and function, which I think every surgeon does to some extent. But I think when you're dealing with endometriosis, you have to think of it as a thoracic surgeon. You have to think of things as a bowel surgeon, as an abdominal wall surgeon, as a gynecologist, as a urologist, as a physical therapist, as an orthopod, as a neurologist. Like, there are so many disciplines that span across the treatment of endometriosis. And for us to really unpack and unravel this disease, you have to listen. You know, Sally likes my analogy of endometriosis and pelvic pain is sort of like a ball of yarn with 1,000 loose ends. You know, if you don't pull on all of them, it doesn't unravel. It only gets tighter if you only sort of pull on one. And so my view and my sort of worldview about pelvic pain and endometriosis is that we have to take a very broad look at the patient beyond our personal specialties. And that gets us to the point where we can actually help patients and really make a living doing so.
Now, you have a question you ask all of the endometriosis patients. And I also love that, in addition to the ball of yarn, I also love that you asked that question, because a PT usually asks that, but how amazing it is that the urologist asked it. What's this famous question?
I have a secret. I stole it from a physical therapist.
Oh, well, it wasn't me, so we hate them.
It wasn't you, but it was from a physical therapist. So
Right.
I always ask patients, is your bladder nice to you? And they say, what does that mean? And I say, whatever you want it to. You tell me. And then they, you know, you uncover all sorts of things that nobody's ever specifically asked about, or that people have neglected to ask about, or that patients haven't felt forthcoming about or didn't feel comfortable. My favorite answer is, my bladder's nice to me. And I go, tell me how often you go to the bathroom. And they say, oh, you know, every like 20 minutes, but I drink a lot of water. No. How often do you wake up at night? Only like 6 or 7 times. I'm like, so you're waking up every hour? How do you function? She's like, I don't really function. So I can ask, is your bladder nice to you? I think, is your rectum nice to you is a question that Dr. Raccuia is going to ask patients. That one seems a little, you know, out of my league, but is your bladder nice to you is my question.
Right. And I think, you know, as we all sort of like, you know, laugh a little at what you're saying, we realize it's so true, because I don't think patients get that. By the way, you're not supposed to get up to pee in the middle of the night, you know, and you're not supposed to go to run and either dribble or have to come home and empty your bladder before you go out again. And I don't think people ever get that. So I love the freedom of, is your bladder nice to you? Now, is your rectum nice to you? Dr. Raccuia, you are our general surgeon extraordinaire. Do you want to introduce yourself a little bit and tell everybody how you ended up working in endometriosis, because you have a very different background?
Yeah, well, my background really is liver and pancreas surgery. I have an extensive experience with sarcomas. Sarcomas, as you know, they occur abdominal sarcomas, anywhere from the diaphragm to what I say the pee-pee. So the interesting thing is, it's not only the rectum, there are so many other organs involved with endometriosis. And what's interesting is most of my work with, I would say 90% with tumors, we do imaging and we have a target. Very frequently with the endometriosis, the imaging is not, let's say, exact enough to show us lesions. So when the surgery is done, we have to be prepared to really almost work on any organ. And as you know, getting to the rectum, I am, and the intestines, I am a big, big, big proponent of organ conservation. What do I mean by that? These are mostly young women who have a very difficult problem that I've always said it's a cancer without being a cancer. But with cancers, we do big, what we call en bloc resections, where we remove areas of tumor with normal tissue around it. With endometriosis, there's mostly young women, and during the course of their lifetime, there's a possibility they might need other surgery for other things. So I really take a minimalist approach in terms of organ conservation. For example, with the rectum, shavings, doing the wall. If you have to, you can go full thickness without doing a tubular resection, because again, these are young women who during the course of their lifetime might again need surgery for something else. And one of my mentors stressed, when you do the first surgery, you must be planning the second one at that time. So it's really important that there's a good balance between what's removed and getting all the tissue out.
Dr. Orady, when you first started, oops, very unlikely for me to ever get a call because I have no life but the Endo Summit, so I apologize for that. Dr. Orady, when you started your training in GYN surgery, was there so much discussion that endometriosis was a multidisciplinary approach, or was it a big focus on reproductive medicine and fertility?
So honestly, when I started training as a resident, this is now 20, 25 years ago, I was actually at University of Western Ontario was when I was first exposed to endometriosis, because Dr. Vilos was one of the first people to do CO2 laser for endometriosis. So it was one of the first centers in Canada where they were doing CO2 laser ablation. So I was actually lucky to get exposed really quite early in medical school and all that to endometriosis. But the discussion wasn't about excision. It was mostly about fulguration with CO2 laser, and anything that was more severe, they would take to GYN oncology. And I actually, one of my mentors was a GYN oncologist, and he used to do more excisional surgery. And because he's a GYN oncologist, he would deal with rectal, bladder, ureter, and everything. And that was what's kind of like fascinated me about endometriosis, was that I was, fascinated with surgery and watching these amazing people. Like his name was Dr. Sugimoto in medical school, and Dr. Vilos doing these endometriosis surgeries, cancer surgeries, and things like that. I just knew that I had to be a pelvic surgeon and that I wanted to be able to fix it all. After I went to residency was when I really developed a passion for minimally invasive surgery. I went to Ohio State University, and they were doing a study looking at cancer surgery, open versus laparoscopic. I know this is an old study now, but you have to realize we're talking about early 2000s. When laparoscopic surgery was not that common. And every time the patient would be randomized to laparoscopy, all the other residents would like roll their eyes, oh my God, we're going to be in there forever, blah, blah, blah. And I'd be like, so I did all the laparoscopic surgeries in that study. And it just was amazing how well you can see with the camera and getting the dissection and getting in there. And I truly felt that this is something you could deal with, you could do that you could do. And I have such patients that whenever we would do an open surgery and I would see how much pain they were in from this abdominal incision, and 2 weeks later they were still barely walking into the office, and compared to the laparoscopic patients who they'd go home the same day and 2 weeks later they'd be almost back to their normal life. I was like, we have to do this. There's no reason why we should be opening patients for benign disease. And that's really what began the road. So I was just lucky, I guess, that with my passion, I also found amazing mentors, both in medical school and residency. And then afterwards, it just took me on this path of minimally invasive surgery for endometriosis and learning truly. In Canada, there is an advantage that they really do focus on diagnostics, the complexity of history taking, the complexity of pelvic examination. We didn't rely so much on imaging. And really we spent almost multiple units just on history taking, just on the subtleties of, if you have pain before your period, then that's usually endometriosis. If you have pain during your period with heavy bleeding, that's usually adenomyosis. If you have spotting pre and post period, it's usually polyps. Like just the diagnostic capability of already knowing what the differential diagnosis is, just by listening to the patient. I haven't even touched the patient yet. I already know what I'm looking for. And that's something I really was a benefit to me, training in Canada and then training in such great places such as Ohio State as a resident, that took me down this path. And then I just flew with it from there, you know, over the last 20 years, and having wonderful mentors at SLS, AAGL, wonderful surgeons that did endometriosis. I was like a little puppy dog. I'd like follow them around. Let me see. And I guess hopefully now I'm one of those. So
right now you're the big dog. You're not
Yeah.
the puppy dog.
Yeah.
So, Joe, I wonder, you know, what is your pre-surgical planning like for somebody with endometriosis?
Well, I mean, it depends. You allude to the fact that, this is all done minimally invasive. But reality is, 2 to 3% of these cases, we do approach openly. This is number one. Number two, if there is an image with a big lesion, and of course, every effort is made to do this, and we do them robotically. I think the planning is based on what we find in the operating room, because most of the time, these lesions are not image sensitive. So a lot of patients that we see go into the operating room with pain. And of that, I think from our statistics, about 80% of them, we find endometriosis or something causing the pain. So in terms of planning from a technical aspect, I hate to say this, it's about being prepared to deal with an issue, i.e. vis-a-vis diaphragm, bowel, abdominal wall, and with Yaniv's case, a ureter involvement or a kidney that becomes dead or hypertrophic. So there's a lot of things that we see, and I would say the vast majority of them, putting aside endometriomas and large lesions in the pelvic outside the ovary, most of the time we make decisions in the operating room because we don't have a disease that's image sensitive.
Now you're a data guy and a numbers man, so I don't mean to put you on the spot, and we can also move to Yaniv for a minute if you have to look up the answer, but you have been collecting for many years at this point how many lesions people have that actually fall outside of the reproductive organs. Do you remember what your statistics are looking like these days?
It's about if you just look at it, I say gonadal. We've had this discussion multiple times, you and I, Sal, but I say gonadal in terms of, and you say reproductive, which is probably a nicer way to say it. If you consider the rectum, the ureter, abdominal wall, diaphragm, I would say about 65% of the patients have disease outside of the realm of the usual GYN surgeon. Vis-a-vis, one can develop skills in these areas, but it's really important that you have a team that's able to look at each level of this disease and be able to treat it adequately and expeditiously with a good experience, meaning that you need to have some numbers under your belt. And this is where I think the forte of this team has come through, because each one of us has, given our input in terms of making sure that that patient ends up with a good result.
Yeah. Now, Dr. Larish, we talked about that you ask, is the bladder nice to you? I always say, is your bladder happy? I don't know, it's a slight difference, but what is your surgical planning like? What are the questions that you ask a patient? Because you sort of like to figure out if you belong there, but as a multidisciplinary specialist, but also you have different techniques that nobody else in this field offers. And if they are people who would qualify for some of those techniques, something like the Rotox, which you may have to explain.
Sure. So as I mentioned earlier, part of what I do is functional urology. And function oftentimes has something to do with form, meaning you have a lesion on the bladder, you have a endometriotic implant on the bladder, you have an endometriotic implant on the ureter. those, are typically, the form questions are relatively easy because they're either going to be so big that they're seen on imaging or so small that they can be dealt with intraoperatively in real time, even if you don't have knowledge of them ahead of time. The function questions are tough because a patient that's asleep is not going to be able to answer a question about, are they having urgency, meaning when they have to go, do they have to go? Are they having frequency, meaning that they're going often? Are they having incomplete emptying, meaning they feel as though when they finish urinating, there's still urine in the bladder? Are they having nocturia, meaning are they waking up at night to pee? One of the questions I like to ask is, do you know about where every Starbucks is between point A and point B in your, local area? And the ones that go, oh yeah, I need to know where every Starbucks is because I need to pee, on the way to XYZ, I got to go. So I think that those questions are important. I think that there are questions about leakage of urine, which is really tough. I mean, you can ask people, do you have incontinence? And they'll say no. And you say, hey, let me ask you a question. When you have severe urge and you can't make it to the bathroom, what happens? They go, oh yeah, I have a couple of drops on the panty line. Okay, no, that's incontinence, right? So there's a cognitive sort of disconnect between the two, or maybe it's the way that we're asking.
Well, and
So
I would
those are
even
all-
back up. If the patient is wearing a panty liner in case it's happening, it's not just a few drops and it's not just only an isolated incident, right?
Sure, 100%. One of the questions I started asking recently, which I think is sort of interesting, and we are sort of writing the protocol now for a study about it, is when you are done having a bowel movement, do you find it difficult to get clean? And they say, what do you mean? And you say, you have to wipe 1,000 times before you get clean, and is it still dirty at the end of it? And it's amazing how many people actually say that's actually happening. And that is a function question, right? They're having rectal fecal incontinence because either they have a true endometriotic lesion on the rectum, or they have a hypogastric nerve that's being impacted by the endometriosis. So all of these things are important because if you have pure overactive bladder / urgency / urge incontinence, if your bladder is just spasming, and that's the only thing that's going on between the bladder and the rectum, if that's the only thing that's sort of bothering them, then the solution for that is at the time of resection of endometriosis, you can actually chemodenervate the bladder, meaning you can put Botox into the bladder muscle wall. The same Botox that people use for the forehead, for the wrinkles, sort of relaxes the muscles in the skin, and that's why you get a nice smooth forehead. It's the same stuff. If we put that directly into the bladder muscle, the bladder stops spasming. And those spasms are interpreted by the brain as I need to pee, irrespective of if there's a lot of urine in the bladder or not. So it's a false signal, right? So Botox would be great for somebody who has just bladder dysfunction. For the patients who have bladder dysfunction on the one hand, but also have rectal fecal incontinence, Botox will take care of the bladder part, but it's not going to address the bowel part. And for those patients, I often say, get rid of the endometriosis, see how you feel. If that's the only thing that's left when we're done, then a sacral neuromodulator is the right thing for you. There's all sorts of ways to sort of attack this. But again, I think that the key here is you need a general surgeon, you need a thoracic surgeon, you need a urologist, you need a gynecologist, you need a pain management specialist, you need a reproductive specialist, you need a physical therapist, you need a psychiatrist. The team really needs to be a team because everybody brings their unique approach to solving one of the hardest problems that we can solve in pelvic pain today.
Yeah, definitely. It's a team. So Dr. Orady, you're the captain of the ship, usually as the GYN surgeon. How do you decide? So somebody comes to you, you think they have endometriosis. How do you decide what part of the team you're going to bring in, how to recruit a team? We get a lot of questions about, like, my doctor just called a general surgeon in, like, how do I trust that general surgeon? What goes in it from your side of things And what kinds of symptoms would lead you to believe that you should take multi-specialty care into the OR?
Yeah, so it's difficult, right? It's difficult because you don't know unless someone's been in there before, which I do get those patients where they've had a prior laparoscopy and I already know they have a rectal nodule, I already know they have a ureter stricture, I already know this stuff. If they haven't had prior surgery, it's more difficult. If they've had prior surgery, I already know what I'm dealing with, and I can usually then decide. I work with one of 2 general surgeons and one of 2 urologists, and I've been working with them now for years, so they're kind of getting used to these cases. And before me, they had never really seen endometriosis before, but I helped guide them, and now they have a lot of experience with these types of patients. Now, so if I don't know, if I have prior laparoscopy, then I know. If it's not prior laparoscopy, I go based on a number of things. Number one, their symptoms. So do they have rectal symptoms? Do they have bladder symptoms? Number 2, pelvic examination. I mean, I've examined so many endometriosis patients, I can usually tell if there's any rectal involvement just on rectovaginal examination and examination of the uterosacral ligaments and my own. I do all of my transvaginal ultrasounds all by myself. So I can tell, is this bowel kind of tethered? Is it kind of not moving? Is there adhesions? I can tell based on my ultrasound whether there's some of these symptoms. So it's based on diagnosis, based on their symptoms, my pelvic examination, my ultrasound. Then I decide, okay, does she have a nodule? If she has a nodule, I may do an MRI to see if they can see it. If not, I'll kind of judge whether I want this general surgeon there or not. And then I also go based on patient desire. Sometimes patients are like, you know what, I don't want a bowel resection. In which case, the majority of cases, I would say I don't need to do a bowel resection. I can usually just shave the endometriosis lesion right off the bowel using CO2 laser, and then I can suture the bowel. So I can do a lot of rectal shaving. I can handle most things around the ureter, the bladder, all of that. Unless there's specifically a stricture with a hydronephrosis on ultrasound or on MRI where I know that a portion of the ureter needs to be removed, then I will have a general surgeon there. I mean, a urologist there. In terms of bladder lesions, again, I can see them on ultrasound, sometimes on MRI. And again, bladder symptoms. I do a cystoscopy myself on every single patient that I see. And if there are lesions in the bladder, I do treat it with bladder installation and work with urology to do, sometimes they'll go in and actually laser or biopsy those lesions off of the inside of the bladder. Anything on the outside of the bladder, I usually handle myself, again, with just CO2 laser and over sewing. Around the ureter, I dissect and I take care of endometriosis around the ureter, only if there's a stricture, in which case there will be a hydronephrosis or something, or hydroureter on imaging. So it's a combination of good diagnosis by history and physical examination, doing my own ultrasound, deciding whether or not I need an MRI, and then choosing, do I need a general surgeon there or not, or do I need a urologist there or not? I mean, the ideal was I would have someone available from both teams at all times, but that's just not feasible in the U.S. healthcare system, unfortunately. Otherwise, you know, they can't just stand on standby and not do anything for hours and hours. So it is a subtle thing, and occasionally I'm surprised. I go in, I don't think there's something, and I find something, in which case a second surgery may be needed, in which case I'll plan out everything and have them ready, and I'll decide what to do. But the majority of times I can handle most things on my own. And then I will have general surgery urology for the more severe things. Diaphragm, I usually deal with by myself, unless it's full thickness again. Yeah.
Sally, Sally.
Go ahead.
That's very nice, and your description is extremely capable, and this is really what endometrial surgeons need to be. Our approach is slightly different, and we have the luxury of having all the specialists there for every case, in the sense that each one of us is prepared to participate with lesions that might be specific to our specialty. So when we see these patients, we all do it as a intraoperative team approach where everyone's prepared to do whatever part they need to do. And I think that is a really good, strong attitude in the ability to be able to treat these patients, let's say at the same sitting. And I think for the most part, a lot of these cases, we do have surprises because these are not image sensitive lesions. And the other thing, just to comment, rectal involvement is the most common of places for, the intestinal endometriosis. However, we have to understand lesions in the sigmoid, lesions in the proximal rectum, you're not going to feel them preoperatively. And those, I have to say, come up quite a bit, albeit not as common as the rectal lesions, but we do see a fair number of patients, especially the reoperative patients, where there is a lesion inside of an adhesion from the previous surgery. And most of the doctors have taken down the sigmoid, which is part of the colon above the rectum. So it's essential that we peek in there on the reops. It's essential that we look there on the virgin abdomens, because a lot of times there's involvement beyond the quote unquote pelvic rectum, I'll say.
Yeah, now, Dr. Orady was discussing shaving versus resection. We have two excellent videos on our YouTube channel. So I'm not going to run a whole webinar on that this year. We have one, of course, by Dr. Mawad, who publishes in that field. And then we have one by Dr. Mangashkar and Wendy Bingham, who is hiding in our comments, but she is loving seeing Dr. Joe because he's on her scientific board for extra pelvic, not rare. Dr. Joe, shaving versus resection, what would cause you to make one decision versus another? Just very briefly.
Depth, simple, very simple, depth. And you assess the depth of the lesion when you start lifting it off the abdominal wall. Most of these lesions can be taken off while we maintain, the intestines have three layers: a serosa, which is like the roof. Then you have muscularis, which is the beams in the house. And then you have the mucosa, which is, the inside of your living room, let's say. I would say the vast majority of lesions can be taken off. When you say shaving, to what level? To the level of the muscularis. And in those cases, we'll just do a little closure with some suture, but it's all a hands-on intraoperative decision. Lesions that are full thickness, I would say most of our patients do end up getting imaging. You will see full thickness lesions on MRI or a CT scan. The lesions that we're talking about shaving are the ones that we encounter. Some of them might be suspected, most of them not. And the depth of invasion dictates shaving versus excision versus full thickness versus resection. I tend to not want to resect these women in terms of resecting the tube of the intestine, because I believe young people, there's a chance they might need other surgery in their lifetime. So we want to preserve as much organ as possible. And I can't underline that and stress that more than it's essential that you are adept at taking care of each individual as the need arises.
Yeah. Before we talk about kidney, because we have a ton of kidney questions for Dr. Larish, Dr. Orady, I don't think that a lot of our viewers know what the CO2 laser is and the advantage that it can be in taking off those subtle lesions. And I think it's unusual to have a physical therapist who's actually stood and used the lesion before. But I would watch these videos and I'd be like, whatever, what are these people talking about? And then when I was able to dissect chicken skin, raw chicken, and I saw how you could really get right up to the lesion, how much control you have, I was like, oh, I can't believe there's a tool that can do this. Can you just explain what the CO2 laser is so that people know what we're talking about?
Yeah, I mean, I think the CO2 laser is an amazing tool, especially for endometriosis patients, especially for patients who are younger and desire fertility. I mean, CO2 laser is the most precise cutting tool available. I mean, it to the millimeter depth can shave off or cut out lesions on endometriosis. I mean, I agree with Dr. Raccuia. You can have lesions on the sigmoid, on the mesentery of the bowel, often in that sigmoid adhesions, on the surface of the rectum, in the rectum. And you can very precisely with the CO2 laser just circumscribe the lesion, make a circle around it, and then pick it up and then undermine it. And you can actually see where the endometriosis stops and the normal tissue begins, because it literally is the most precise cutting tool available. And you can cut out the lesion to perfect depth while still controlling bleeding, and not causing any kind of thermal damage or damage around, which is what happens when you use things like monopolar scissors or other tools that have heat applied to them. It actually heats up the tissue, and you can cause nearby burns, and it causes less healing, more pain. With the CO2 laser, which is what I use for the majority of my endometriosis cases, I can cut to the most precise level off of any organ, whether it be the bowel, whether it be the uterosacral ligaments, the rectovaginal septum, the bladder. And it's really, truly revolutionized, I think, endometriosis surgery, especially now with the precision of the robot as well. I mean, you are precise to the millimeter. It's incredible. Absolutely.
Are all of us are, not me, because I'm a physical therapist, but all of you are robotic surgeons, that's correct?
Yes.
And all of you, when you teach, because you all are teaching, are you all teaching only robotics, or are you teaching both?
Both.
You can't be robotic without laparoscopy. You have to, the robot is a tool, but the surgery is still laparoscopic, and you still have to be able to do laparoscopic surgery too, which I do occasionally with I do mini micro laparoscopy as well for milder disease. I can use CO2 with mini micro laparoscopy as well. So I can do laparoscopic surgery for like stage 1, stage 2 endometriosis, and remove the endometriosis with just 2-3 millimeter incisions, which is done laparoscopically. So you don't have to use the robot for everything. And I think if you need to learn laparoscopy first before you can do advanced surgery with robotics. So it's
right. We're going to have you on separately just to talk about mini micro laparoscopy, because that's how we met. Really, we had a whole conversation about that and Cirque du Soleil, which was really fabulous. And it's very, very interesting. But on the heels of our kidney discussion last week, we have Dr. Larish here, and people were fascinated by the picture of the kidney you removed, but I wonder, what is the kidney removal typically comes from ureter endometriosis and not from kidney endometriosis itself. Do you want to make a comment on that, doctor?
Oh, sure. So, I mean, that kidney, anybody who loses a kidney to endometriosis is an absolute casualty, right? That's not what's supposed to happen. That's a casualty. That's a casualty of diagnosis or misdiagnosis. It's a casualty of poor surgical technique. It's a casualty of gaslighting somebody and not listening to what they're saying. That's what a loss of a kidney comes from. It comes from endometriosis, not directly on the kidney. It's affecting the ureter and blocking the outflow of urine from the kidney down to the bladder. If you think about it, the kidneys sort of make the urine. There's a series of funnels that come out of the kidney and go to a narrow tube that then goes down into the bladder. That's called the ureter. If you block the tube that drains the kidney at some point says, well, if you're not going to accept the urine that I'm making, I'm just gonna stop doing what I do, and that's a very tenuous situation that can only be sustained for a couple of months before the kidney actually starts losing its function. And so the key is to diagnose early, intervene early, and try to reverse the damage. There is a red line, though, that once crossed, there is no coming back from. The kidney does not regenerate. And so, yeah, I think, people who, see, the issue is people who have endometriosis have chronic pain, right? They have constant pain. And we know that the average amount of time from onset of symptoms to actual diagnosis and treatment is a decade. So if you're in pain for a decade, 10 years, right? And you say, yeah, everything hurts, and today my back hurts, then the doctors that are treating you are going to say, yeah, but everything hurts, and now your back hurts. That's just what happens. But that's not just your back hurting. That's your kidney hurting. So I think that if the diagnosis of endometriosis is suspected, imaging needs to be done. That imaging needs to include cross-sectional imaging, albeit a CT or an MRI, whatever your weapon of choice is for imaging. If there is any evidence of obstruction of the tube, which you would see by swelling of the kidney or hydronephrosis, then you have to get into functional studies. And there's something called a renal scan that will tell you to what degree is the kidney obstructed, to what degree is that kidney participating in the overall filtration of the bloodstream. There are people who are 22, 23 years old who get endometriosis with obstruction and develop new onset hypertension, high blood pressure. And that high blood pressure is actually what gets them diagnosed, because somebody says, wait a minute, you're 22, why do you have high blood pressure? Let's do some imaging. Oh, you have hydronephrosis. Oh, you have a cyst in your pelvis. Oh, and then somebody says, oh, aha, we've got it, right? But to get to that point, you've already sort of lost the battle in a way. So again, it all comes down to history and physical. Like if your back hurts and this is a new sign, and this pain is sort of worse during your period, we have a problem, and that should be a big red flag.
Yeah, the first kidney I saw, it's so bad that I have to say the first kidney I saw lost. So the first kidney I saw lost was a woman who was African American, and she wouldn't go back to the GYN surgeon because that surgeon was aggressive with her, and so she was afraid to go to the doctor. Her primary saw the blood pressure rising and just said, people your age in your type of job have high blood pressure. And then it took, I want to say it took another 3 or 4 months for her to show up. At the time, I wasn't treating her at my office in a panic for us to be able to mobilize a team to do the right testing. And by that time, it was too late. So what makes you decide to take the kidney out or to leave them in? Years ago, you used to leave in the kidney because they're complex.
I try not to take out kidneys ever. You're asking if the kidney is dead and irreparable, right?
Yeah.
So there's really only 2 reasons to remove a kidney that's dead and irreparable. Well, 3 reasons. One is if you have high blood pressure as a result of that kidney being blocked. 2 is if you get chronic urinary tract infections because that kidney is sort of harboring bacteria. And 3 is chronic pain from that chronically obstructed non-functional kidney. If you've manipulated a kidney multiple times endoscopically, meaning you've put a stent in, you've taken a stent out, you've put a stent in, you've put dye up, you've taken this out, taken that out, and you find out that the kidney is dead after all of that during the investigation, my concern is that you've seeded the kidney at that point with bacteria. And if that kidney is chronically infected and sort of it's a world of trouble. Dealing with a kidney, removing a kidney is not a simple operation. It's a very difficult operation, potentially dangerous operation. That's in controlled sort of circumstances. If you have an infectious complication from a dead kidney, then it becomes an emergency. And those are just not fun, not for the patient, not for the surgeon. It's just not good. So you're right. We try not to remove anything from anybody if it's not necessary, right? Nobody does surgery just for the sake of doing it. But there are certain circumstances that necessitate the removal of the kidney. And I think, it pains me to do it, but sometimes it has to be done.
Yeah, it's a long procedure. Dr. Orady, how often in your practice do you see these hydronephrosis from the ureteral endometriosis? That was a big word.
So I see more commonly patients with what we call the frozen pelvis, basically where everything is stuck to everything. Basically the whole pelvic wall is all pulled to the center. The rectum is stuck to the uterus. The rectum has a nodule, the uterosacral ligaments, the ureter, all of that pulled in. Generally, when I start the dissection on those ureters are dilated and hydronephrotic. Once I've released them and removed all the endometriosis, it's amazing how fast they become normal. Like they just, I see that at least once a week, honestly, at least, maybe more. In terms of like where there's an actual specific stricture of the ureter that I'd have to call in urology to put a stent or remove the piece of the ureter or something like that, which usually we can just, once we've removed the endometriosis encasing the ureter, it does release, and then we just stent it for a while. I see that maybe once every other month.
Yeah. Now, we know we have that patient and practitioner element to the endometriosis summit. So I can say, as a person with endometriosis, when you're in my teens, I had all the symptoms, but you didn't know that was endometriosis. My first something is really wrong with me sign was flank pain. And I remember I was doing all my pre-med, pre-PT coursework, and I couldn't take my own shoes off because I couldn't bend to get them. And I was like a 22-year-old, and like my mother had to come in and dress my shoes. And then, like, of course, all my pain came with screaming at whoever was in front of me. And I wasn't diagnosed for another 10 years and then had to walk around. I mean, I had the catheter, the whole thing, because then surgery becomes really, really complex. What are early warning signs of disease like this? Because this seems like disease that is deepening and progressing. What are some early warning signs we can look for?
I think certainly flank pain that's cyclical is a big sort of red flag. If you are having flank pain, particularly if it's reproducible, if you say, yeah, once, every month, it's right there, and they can take their finger and point to it, and then it gets better. Or, yeah, I used to have pain right here every time, but then I started birth control, and that's no longer an issue, although sometimes I feel it. It should be a red flag. Blood in the urine, microscopic blood in the urine, big red flag. Frank blood in the urine, even bigger red flag, but that's not an early sign, that's a pretty late sign. But I think if you can take a finger and say it hurts right here, by the way, this is where the kidney is. Right. If you say it hurts right here, that's not the kidney. But if you say it hurts right here, that should give you that should alert your doctor to the fact that the ureter may be in jeopardy.
And how many patients as a GYN come to you with that complaint? Because as a pelvic PT, I get that complaint constantly. And I don't always, now I have a good GYN team of a certain surgeons to send to. I don't always, I get a lot of patients who forget to tell me because they just say it's back pain, and back pain's back pain. Dr. Orady, do you see that a lot? Do you see the urinary complaints a lot?
Yes, I would say at least 25% of my endometriosis patients have urinary complaints. At least, probably more. And interestingly enough, I mean, a lot of them do have, back pain, flank pain, and what's even more interesting is the patients with the worst disease, meaning the ones that have, the frozen pelvis, they have no pain at all now. Like, it's like their brain kind of filters it out, or their nerves are now dead, and they don't. And those, I always tell patients that have no pain and severe disease on exam, those scare me the most, because I know that the disease is infiltrating the pelvis. So it's not.
I will say that if you have that those ladies, those people who are having no pain now had pain at some point.
Yes, they did. If you actually ask them. They did.
You ask them, they tell you, I had it 6 years ago, but I had to live my life and do XYZ, and now it doesn't hurt anymore. And then you see hydronephrosis. Those are really scary. I agree. That's the one to be worried about.
The most scary patients are the ones that now had pain, now it's gone, and you're examining them, and you know they have severe disease. But I see patients with urinary symptoms, at least 25, probably closer to 50% of my patients have some sort of urinary symptoms.
Dr. Joe, how often do you see like, oh, this patient didn't complain about anything, and then you go in there and you're just in there for hours? I've been in with you more than one time when we've had that happen.
I think if you look at the bowels, there has to be a significant stricture to have, let's say, horrible, unrelenting pain. The in-between of nothing and something severe, you can have subtle symptoms, frequent bowel movements, some pelvic pain, some lower back pain. There could be issues with the type of bowel movements. And these are questions to ask, because a lot of times these are, what we call subclinical. But if you, like Yaniv was saying, asking the question, your index of suspicion is higher. So at the same time, it goes patient to patient. You can have a patient with a subtle adhesion that could be extremely symptomatic, and you can have another patient with some bizarre looking abdomen who really complains of minimal symptoms. But like Yaniv said, you got to keep asking. You elicit it because people get used to certain bodily functions, even though they're completely abnormal.
Yeah. Yes, we have an interesting question. I've been sort of picking some of the questions off of the Facebook Live feed, but UTI symptoms with no UTI. I see everybody nodding. We all have a different approach to this. I'm going to let Dr. Orady tell her approach, then I'm going to let Dr. Larish tell his approach, and then as the PT, I might even add my approach, but we'll see. Dr. Orady, UTI, but no UTI symptoms, but no UTI.
Yeah, I mean, UTI symptoms but no UTI is a very common complaint amongst endometriosis patients. It's often associated with actual IC or interstitial cystitis. I do a cystoscopy on every single one of my patients to look inside the bladder, especially if they have urinary symptoms. And the majority of the time, there is some level of inflammation, interstitial cystitis. Sometimes there are actual endometriosis lesions in the bladder wall. My approach is a combination of, number one, treat the endometriosis itself, because we think that the endometriosis and the inflammation in the pelvis causes the painful bladder syndrome, that now the nerves and the bladder itself become inflamed, and this causes this constant cycle of painful bladder, painful urination, frequency, urgency, nocturia, etc. So I'll treat that with combination of surgery and medical treatment for endometriosis. Sorry. I'm gonna bring a little helper here.
He's okay. He needs to be on camera. Look how cute.
All right, yeah. Well, not right now, dude. Okay.
Right.
And then I will treat the urinary symptoms with bladder installation therapy, which is the medications that you put inside the bladder to actually decrease the inflammation and the urgency, frequency, and all of that. And then pelvic floor PT, obviously for the pelvic floor muscle and the tension that they often have in their pelvic floor. So this is a threefold approach: treat the endo, the original cause of the IC, treat the bladder wall and the hypogastric nerve plexus with bladder installations, and then finally treat the pelvic floor and the pelvic floor muscle tension.
Yeah. Dr. Larish, UTI symptoms, but no UTI.
I can't tell you how often somebody shows up to the office and says, I've had so many UTIs. I get them, I don't know, 12 times a year. And you go, where did you get diagnosed? Oh, at the urgent care center. They always test my urine. I always have a UTI, and then they give me antibiotics. And I go, did they tell you have a UTI on the spot, or did they take 3 days to tell you? And they go, no, it's always on the spot. Not possible. Urine culture can't be done on the spot. It takes 3 days to cook, quote unquote, right? So when we track back and we do some data gathering, I'd say like 90% of these patients do not ever have a single organism cultured, growing in the petri dish. So a UTI, by definition, has to have an organism growing in the petri dish, or else it's not a UTI, it's something else. I think about 20% of patients have organisms that are not identified on a normal urine culture. So ureaplasma, mycoplasma, Neisseria gonorrhea, and chlamydia are not going to be identified on a normal urine culture. So I think if somebody's sexually active, it's reasonable to talk to them about the fact that it might make sense to send off that panel. And that will find something 20% of the time, but that means that 80% of the time there is no organism being found. So Mona, you were discussing sort of the treatment for your algorithm is deal with the endo, then deal with the bladder through the lens of basically interstitial cystitis, right? And then physical therapy for the pelvic floor, right? So I agree with the first part and the last part. I personally do not believe that interstitial cystitis exists to the extent, not that it doesn't exist, I just don't believe that it exists to the extent to which we are diagnosing it. I think that true interstitial cystitis, if you look at the original descriptions of it, requires something called a Hunter lesion, an actual mucosal ulcer. And I believe that interstitial cystitis, true interstitial cystitis, is a mucosal problem. It's on the inside of the bladder. For problems that are mucosal, yeah, the installations are amazing. They work great. The problem is that in the last 10,000 patients that I've seen 2 true interstitial cystitis patients in my practice, which means that maybe that's not what we're seeing. Maybe we're seeing a painful bladder syndrome that is coincidental to endometriosis. But what's interesting about that is that that's not a mucosal driven disease. And so mucosal driven therapies, I don't think are going to have the same efficacy as treating muscular disorder, detrusor disorder. So beta-3 agonists, there's a medication called mirabegron or Myrbetriq, anticholinergics, there's a very long list of terrible drugs that, have side effects that are awful. Botox, sacral neuromodulation, we need to shift our thinking of painful bladder syndrome lumped together with interstitial cystitis in the context of endometriosis care, because I think that the two are conflating each other. And that's why we're oftentimes giving out therapies that may not be as efficacious as others can be. So my algorithm is do data analysis. I don't even reculture these patients oftentimes. If they have the data, they have the data. I don't need to prove it the 15th time that they have a negative culture. I'll make sure that they actually don't have a urinary pathogen. We'll deal with the endometriosis. We'll deal with bladder dysfunction preoperatively, and that's really important. You deal with it preoperatively with beta-3 agonists if you can. We try to not use anticholinergics because of the constipation that they cause, and oftentimes all of our patients are also constipated, so that is a problem. So rule out the urinary pathogen, preoperatively treat the bladder with beta-3 agonists if you can, treat the endometriosis, treat the overactive urge bladder with Botox at the time of surgery, not as a separate procedure, just take care of it. And if you have to restore nerve function rather than ablate nerve function, not ablation, okay? Not ablation in the context of ablating endometriosis, but if you have to ablate nerve function, meaning you want to stop the nerve from firing, then sacral neuromodulation is probably an ideal therapy to do that with. But again, I think that in order to really get this right, you need a team. That's the bottom line.
Right. Well, I'm going to give you the third opinion on UTI symptoms without UTI. And that's why you need a team approach, because one person may be doing this and one person, and it has to be everybody working all together. But certainly Dr. Orady and I come from the SLS Maurice Chung School of Bladder Education. So our approach is slightly different, but here are the things I look for UTI symptoms with no UTI. I do like to talk to the doctor about the microgen. That's a whole other thing we can have a conversation about. There are some conflicting opinions about that, but I have seen it enough that these patients have been administered and over administered antibiotics that are completely useless for their bladder, and actually they need something else, right? So I've seen that. Based on our conversations here, we had Dr. Larish and Dr. Chung. For those of you that don't know Dr. Chung, he founded that evil twins concept between endometriosis and IC. And Dr. Chung and Dr. Larish had very interesting conversation, unfiltered, here last year. And as a clinician, my takeaway going forward with all my patients was that we're right. We shouldn't use the mucosal lining to treat what isn't coming from the mucosa. And the inflammation likely is on the outside of the bladder. But the other portion of the inflammation is that it's a neural feedback loop to S2, 3, and 4. And so I actually modulated my physical therapy techniques. Instead of treating the bladder directly, what am I doing to the sacral nerve? So I think, you do that with the device and with a lot of other things, but how are we treating S2, 3, 4? What feedback as a physical therapist am I giving into that? What are we doing to down regulate that pathway? That I actually changed what I was doing as a clinician based on these Endo Summit Lives that I'm hosting. And I think when people do the installations to the inside of the bladder and they work, it's because they're modulating this S2, 3, 4, right? But then, and everybody usually thinks I'm a crazy person and I don't have my little partner in crime that backs me on this. I, for whatever reason, believe that urinary urgency really comes from an upregulation to the ilioinguinal nerve. I see this at least once a week. If I don't see it every day when I'm practicing every day. And I think that urgency that you get from this one specific nerve, whether the nerve was stretched or aggravated during sidewall surgery, whether it's an abdominal wall injury, whether it's how the trocar went in, or whether it's a full hernia, that's another discussion. But I can pick up these just in a conversation. I actually picked up 4 of these problems with this nerve. Well, I have a UTI and nothing is working. And then when I send the nerve for somebody to evaluate, instantly the pain stops, whether you put lidocaine into the nerve or you evaluate it a different way. And so that's like something that's sort of like unique to what I look at, UTI, no UTI symptoms. I feel like Joe is ready to kill us. He's ready to talk about bowel, I feel like. But
I'm fine. This is great.
yeah, I mean, Joe approaches ilioinguinal very, very differently than even the rest of us, and could tell you about different symptoms, which is why we like a team and we like to have a whole panel. So as we close out, because it's earlier, Dr. Orady's on the West Coast, and we're here on the East Coast, and I want to talk about Endo Summit 2022. We will be in Celebration, Florida, which is outside of Orlando. So great time to go to Disney, great time to go to Universal. But if you're not able to come in person, we have a virtual opportunity. We are expanding that virtual opportunity. And anyone who wants to high five someone on why that's being expanded, you can thank Dr. Larish. Because 2 weeks ago, he said to me, like, are you crazy? You're gonna, and we know what Florida is like with the virus, right? But he said, like, people are gonna want to sit at home. And so right after I hung up with him, we revamped the entire way the virtual program will be. So anyone who likes that virtual program, you should find him, give him a little high five, little, shout out to him. But let's start. Dr. Orady, you have a very interesting conversation that's going to go on fluids and Firefly. But aside from that, what are you looking forward to in the Endometriosis Summit 2022?
Honestly, it's just sharing ideas, exchanging ideas with other endometriosis surgeons, urologists, general surgeons, which is also what I look forward to every time I go to SLS. It's just sharing ideas, you know, talking about our problem patients that we don't know how to fix them, and you know, and also seeing the impact that what we do has on people. I mean, I think that's the most amazing thing is when I went to Endo Summit the first time, I mean, I really saw how much passion there was, how much it's not just it impacts each one of us as a clinician, as a person, as a woman, but also seeing the impact on all the people that bring their stories and talk about endometriosis. It just kind of, not to say validates what we do, but it just makes me proud that we're part of this larger movement to really help these women with endometriosis that are so much more common than anybody would ever guess.
We love her. We didn't pay her to say any of that. But I loved, you know, last year they turned on the camera for the live surgery. And of course, I was sitting in Miami and the live camera was somewhere in Orlando. And they turned it on and it was Dr. Redan, Dr. McDonald. It was like, and like all, I'm like, why? They're all there and we're not there, you know? So it's nice to see everyone. Dr. Larish, you will be joining us one way or another. What are you looking forward to about the Endometriosis Summit 2022?
So for me, it's always a really reaffirming conference. It sort of gives me a lot of, it gives me time to reflect a little bit when I see the sea of faces that we've either impacted directly or impacted indirectly or may impact in the future. And the fact that we're getting the word out and changing we're really elevating the standard of care by being there. And when I say we, I don't mean necessarily the doctors. I mean, everybody who attends the conference is taking an active part in elevating the standard of care. To me, that's the most powerful sort of moment and sort of gives me fuel for another 364 days after that. I got to take one day off, so 364 days.
Well, sometimes we every other year we do the fertility conference, so sometimes that gives you a little break in between of getting your fix. Dr. Raccuia is an inspiration for a very interesting activity we're going to have called the surgical boardroom. And it's an opportunity. We do something similar at SLS, but the surgical boardroom is a chance for doctors to bring cases to their peers. It is going to be a doctors only activity, but he's the inspiration. So we wanted to share. And you can share these cases that maybe have interesting nuances or something you want to discuss with another professional with this entire boardroom and have sort of this open conversation to move your narrative as a physician forward. Did you know that we were doing that because of you?
No, thank you.
Right. No, so I was told you do this in general surgery and that it was like, I thought it was the greatest idea ever. And so now
we do it in, I belong to an international French surgical society. And the first day is clinical cases. And I think the way to approach it has been you present the case and then you ask the audience what they would do at that particular moment in time. And then the case goes on, then you ask the audience again, what's the next step? And I think it exposes some of us to share our feelings and techniques with surgeries. And I just want to add, just go backward 1 second, over the endometriosis summits, and I've experienced this with other types of surgery, where you say, we need to do excisional surgery. Everybody looks at you like you're crazy. Oh my God, am I crazy? And then time goes on, you explain and you show that, this is a multidisciplinary problem, that you need multiple surgeons. And then years later, which is wonderful, people are saying, yeah, I know that. I know that stat. Of course, most of it's outside the gonads, of course. And it's a really nice progression because at the first venture, here we are, we're fighting in terms of what needs to be done. And now I think we've, accumulated a very good group of people that understand, and this will be developed with the same approach in mind. Rather than fighting, ablate it, don't ablate it. And my last thing I would say is, if you're a gynecologist and you see an endometriosis you can't get out, leave it alone. And then let someone else deal with it.
Yeah, I think we have we feel like change is so slow coming, but we have come a long way. First of all, conversations like this never happened 10 years ago, right? We probably would have had to beg the bowel surgeon to come in. Now we have a whole team. We have, Mona's doing microsurgery, and these conversations didn't happen. But the other piece I will tell you for sure that never happened is we never just accepted that these patients were going to need physical rehabilitation afterwards, which is the PT piece. I mean, I was for a long time the only PT at these conferences. So it's nice to see change happening. If you want to head to the Endometriosis Summit, tickets are now on sale. www.theendometriosissummit.com. We had our first price increase on Saturday, and so there may be more price increases. So if the Endometriosis Summit interests you, I suggest that you purchase your ticket. Well, this is it for tonight. I believe next Monday we're talking pelvic pain. I have to look that up. But I want to thank everybody for being here and for taking your time out. It has meant a lot to me. And we hope that our faculty got something from it too.
Thank you so much for inviting us. Really, it's my
Thank
honor.
you, Sally.
It's really an honor to see everybody. And next week I'll be broadcasting from Florida. So this is sort of our last New Jersey broadcast for a while. Take care, everyone.
Good night.
Bye.
Good night.
Good night.